I'd just like to start off and talk about the centre that I head, which is part of the University of Queensland and based at the Mater Hospitals. And it's been established since 1997 to do research, teaching and clinical work and focusing on the care of adults with intellectual disability. And you might say, why adults with intellectual disability? What this arose from is in the late 80s, some developmental paediatricians in Melbourne, a guy called Philip Graves, which I particularly like because I collect funny names, and therefore he was Dr. Phil Graves, if you work it out. Anyway, Philip Graves and his compatriot decided that they were suddenly seeing as paediatrician 28-year-olds. And this didn't seem right somehow, and there was no interest from the medical profession in providing care for adults with intellectual disabilities. They took the opportunity that befell them by actually changing the positions for doctors in institutions to establish 2 academic centres at Monash and Melbourne University to try to improve the generic support amongst the generic healthcare system for adults with intellectual disability. And I was pottering around in my medical career in a directionless phase and kind of fell into this, to be honest. I fell into this. And applied for this job at Melbourne University in 1992 because I decided that I'd like to be a smart ass and talk to people and feel important. I also had a profound interest in social justice issues, which has dogged my whole life and career. Partly as a result of growing up in Tasmania. You can laugh now. People mainly laugh when you mention Tasmania. But really because I grew up in a suburb that was very poor. And I saw for myself as I grew up that although I was part of a middle-class family, that it wasn't my talents that got me to the top. It was actually my family that got me to the top of the pile and going into medicine. And I saw this, and I saw many kids that were very gifted not go anywhere in terms of a career because of their socio-economic position. And so it was with that context and having done a couple of years training as a psychiatrist, qualified as a GP both in New Zealand and Australia, which is incredibly stupid, to be frank, doing exams in 2 different countries is unwise at best, and doing some obstetrics for a while and delivering babies. I fell into this kind of career. And my interest was not in research. And what I'm about to tell you is a journey over 20 years, which has been, in fact, very much based on research. I had great scepticism about research. And I'll get to the love in the time of randomised controlled trials to explain to you what's that all about a little way down the track. I'd first like to acknowledge people with intellectual disabilities and their families particularly. Now, this sounds kind of trite, but in fact it's not trite. They have taught me a great deal over time, and it's been their generosity of spirit. And in fact, the humility that you see in people with intellectual disabilities who see things for what they are. And they bring a great gift to us in that way. And the other thing, and I often say to my wife, I really should give up clinical practice because it's just there's too many things I've got to do. And she says to me, I don't think you should. And I say, well, it'd be a lot easier, I'd have more time. She says, but every time you run a clinic on Fridays, you come back inspired. And I'm often inspired by families. And the thing that inspires me in the families is really their expression of love. And the fact that they are so with their children, their adult children. Only a couple of weeks ago, I'm sitting in my clinic and a man comes in. And as a doctor, as he walked through the door, I diagnosed an inoperable tumour. That was my gut reaction, as his nodes were spread out like this. I didn't know. He's not my patient. His 40-year-old daughter is my patient. And sure enough, that's exactly what was going on. He's now been diagnosed with an inoperable tumour. And I can tell you that they are still struggling to get services, adequate services, for their child that suits them. Both of these people are in their 80s and one of them terminally ill. So what David says about disability services is absolutely true. And I'd like him to thank that, and also for Grant, except that they pinched a number of my really good lines, which I think is mildly offensive. So I'm genuine about thanking people with intellectual disabilities and their families because they are absolutely quite inspirational in their lives and teach us a lot. Disability Services Queensland, they keep changing the name, but essentially you know who I mean, and Queensland Health also fund this centre in its entirety, along with support from University of Queensland and the Mater I should have in there, who very generously has supported us over the years, and the NHMRC, ARC, and various other granting organisations. So what I'm going to talk about the who, the why, the what of health and intellectual disability. I'm focusing very much on health, but believe me when I tell you health is not really just about doctors and nurses and things like that. It's very much a broader context, and that's what the NDIS is trying to address. And so that point has already been made. What can be done, what we did, and what's happened, and what is possible next. And I think the possible next is up to you and our society, but there's a whole lot of things that do need to happen. Who are these people? These are a number of people that I actually see that as patients, and they've given me permission to use their stories and names because they've developed a level of trust. These people vary from Stephen up on the screen right, who has a full-time job, has worked for 17 years in employment, owned a house, applied to the Commonwealth Bank of Australia for a loan, and they told him they wouldn't give it to him because he had Down syndrome, until his parents pointed out that actually might be discrimination, and he got a loan. And he has a rich life where he does a variety of things. He does lots of support. Next to him is Michael, who lives in a small institution, has a condition that means that he sometimes actually deliberately eats himself, and he can't control this, and that's why his hands are in splints. Michael has, because of some serious lobbying of government, now has community access and goes out, and he loves those exchanges. If you met him here, you'd say to yourself, how can I communicate with this guy? This is really difficult. But I can tell you that he picks up all the absolutely exquisite jokes that I make, and laughs outrageously with spasm, in fact. It's a most extraordinary thing. And I'm sure this guy, because it's very difficult I'm sure this guy's got incredibly good cognitive function. But what we've got is an incredibly diverse group of people, I'm telling you. They range from people who are quite independent to people that require a lot of support from society. As is already said, we're probably talking about 300,000 to 500,000 Australians. And that's a hell of a lot of people, equivalent in fact to the Indigenous population of Australia. And they die, if they have a severe and profound intellectual disability, up to 20 years younger than the rest of us. And if they have a mild disability, 7 years younger than the rest of us. Grant made that point, I think, quite well, because the reality is, even if we get those figures much better, and we need to, in fact, I have threatened, I haven't mentioned this to David, but I have threatened to my staff that if it keeps going like this, I'm going to have Notice the Gap tattooed across my backside, and I'm going to ride naked to Canberra to make the point, because we are not noticing this healthcare gap. And David will probably join me, I imagine. He's suddenly gone quiet. Okay, the what? So what have we got? I've already mentioned the mortality rate. When I first started in this area, I was surprised by the animosity towards the medical profession in this area and the healthcare professions generally. And I was also further surprised when I looked at the literature and started looking at it, that in fact, in a field that considers themselves as great they talk to everybody and are very open to communication, that in fact they'd never talked. Only in one case had they talked to the medical profession, and that was 20 GPs in Bristol. Well, that was informative, wasn't it? And I have to tell you, GPs are the people that the professionals these people see most, according to the literature. So there is really no kind of understanding of what it was like for the coalface to deliver healthcare to this population. And it's difficult. It's very difficult. And partly that's because of the difficulties with communication. Because when you come and see me, and in fact I'm consulting in a couple of hours, when you come and see me, you come in and you tell me your story. If you don't tell me your story, we call it a medical history, but it's a story. And if you can't tell me what your story is, I'm really pushed to work out what the hell's going on. Even more so if it's a psychiatric disorder or a mental disorder. So the GPs were really struggling. And we did a survey, a random survey of 1,000 GPs through Australia to find out what they think, essentially, about this population. And they did say, we're reasonably confident, we feel okay about this, but it is a big challenge. They also said that once we develop a relationship with these people, we feel we've even got a stronger bond with this group than we have with people without a disability, because we've developed this relationship. And that is, in fact, one of the key aspects of general practice. That is this long-term, longitudinal relationship. And building on that is crucial. I think one of the most distressing things I've seen during my lifetime is the destruction of general practice in terms of being central to healthcare delivery. And this is bad news for patient care, I can tell you. It's also bad news for the economy because it's economic to run a strong primary care system. Anyway, that's what they told us about people with intellectual disability. When you looked at the literature, what you found, and when you saw people with intellectual disabilities, is there's lots of unrecognised disease. Not a surprise. In fact, a study by Helen Bange in the North Shore of Sydney, actually a wealthy area, found that over five conditions per person existed in adults with intellectual disability, half of which poorly managed or, in fact, not recognised at all. Only 2 weeks ago, I discovered a massive inguinal hernia in a patient which has possibly been there for years and could have strangulated at any time. And the reason they didn't undress him is, God only knows why, to be honest, but he was rather shy, and people don't go that far. And these are some of the other examples. You're having mic problems, eh? I tell you what, I don't normally need mic if I'm going to get going. Unrecognised pain is really quite common. And I'll just show you some examples here, and I've put up these pictures here. And you can see that that's the hip bone there and the hip bone there. This is the pelvis. This is 10 centimetres wide. How do I know it's 10 centimetres wide? Because I did obstetrics, and that's how wide it is. Heads have to go through there. And what you're seeing here is faeces. I know it's breakfast. Constipation is extremely common in this population. Indeed, David did say I might disturb you. I've had a patient who was admitted to PA hospital vomiting faeces because they were so seriously constipated. That's extraordinary in this time, this age. And it keeps happening. This is not an unusual characteristic. You can see just over here, in fact, what we've got is the pointy end of your elbow is called the olecranon. I don't know why. And it's been smashed off in this person. This went undiagnosed for 2 weeks, before it was picked up. Why? Because they don't tell you necessarily something's going on. People don't necessarily look. And this was in a cold climate, so they wear long sleeves. And dental care, I've once seen a man who wandered around my consulting room and I could not get near him. And all I could say to the staff, and I'm not little, I used to play Aussie rules at a fairly high level and I could get near people. And I said to the staff, take him to the dental hospital because his teeth look like that and see what you can do. They took him there, he was given a general anaesthetic, they took out 8 teeth, they put in some fillings, and the next time he sat by the table with me. It's very simple stuff. It's very simple stuff. So you can see there's a whole lot of reasons that there's people that were missing. From poor management of epilepsy, I've in fact seen people where the parents have said to me, he's not concentrating very well, and the person's having active epileptic fits sitting in the seat in front of me. Overuse of medications, often people 12 or more medications, and that comes with its risk. We don't usually test medications we do test them, but once they're delivered, to find out how they interact over time. So combining medications is extremely risky business. And medication side effects in a population that can't tell you they're having side effects is really problematic. Okay, there's the good news. In fact, this Peter sitting there, is a man who came to see me on 4 anticonvulsants at massive doses. And over a couple of years, we halved the number of anticonvulsants and halved the doses of the ones that he was on. And I knew I'd crack through when the staff said to me, he's really quite demanding now. And I thought, yeah, go for it, Peter. Okay. And that's a fractured femur, this bone here. Requires you to drive your Kawasaki into a tree or something.